Спасибо. Good afternoon. We'll continue to our lecture about examination of the patient with diseases of digestive system. First of all, we'll finish examination of the patient with gastrointestinal tract pathology. Last lecture we stopped on disordered defecation, and which indicates effect of digestive process. And if we are talking about pathology of intestine, it characterizes motor activity of intestine and absorptive function of large intestine. Disordered defecation may be manifested two types, diarrhea or constipation. If you are talking about diarrhea, it appears due to accelerated peristalsis, when the process absorption disturbed and all liquid hyrus will be evacuated. This problem appears as result acute or chronic intestinal infections. If we are talking about small intestine, it will be enteritis. If a large intestine, colitis. We must remember about some intoxication, which may be exogenous, especially it is characteristic for people which work with arsenic or mercury, and organism gradually will be intoxicated. And we can remember about endogenous intoxication, which appears due to disorderly detoxicated function of liver and kidney. We are talking about uremia as a result of progressive kidney insufficiency. Some metabolic disorders, diabetes mellitus, gout, which involve in pathological process, all organs and system. And specific endocrine disorders, thyrotoxicosis. If you remember, we said about thyroid gland is a more active gland of endocrine system, which regulate the activity of other endocrine organs and some inner organs, for cardiovascular and digestive system. And if the level thyroid enzymes in the blood increases, motor activity of gastrointestinal tract also increases. And we said due to accelerated peristalsis and disordered absorptive function, patient complains of diarrhea. Diarrhea appears as a result of disordered digestive process. Usually it is characteristic for pancreatic insufficiency because stomach insufficiency may be compensated with pancreas activity. If patient with exogenous pancreatic insufficiency, digestive process cannot be finished, especially cannot be completely digested fat, carbohydrate, and some proteins. We distinguish two types of dyspepsia. Fermentative dyspepsia, which appears due to deranged digestion of carbohydrates. Such diarrhea is characterized with liquid, foamy, light color feces. Fermentative dyspepsia, which appears due to deranged digestion of carbohydrates, is characterized with liquid, light color, foamy feces. Putrefactive dyspepsia, putrid dyspepsia, appears due to significant depression of stomach and pancreas activity, and if the both organs activity decreases, you understand will be problem with digestive of protein. Feces becomes with specific unpleasant odor. They are dark and liquid. We can differentiate diarrhea depending on its duration. Paradoxical or intermittent diarrhea appears short time Usually not needed specific treatment because it is characteristic for traveling people and appears due to changing of water and some dietary predilection. Persistent diarrhea needed attention of the doctor because more often it is a symptom of some pathology, intestine or some other organs. And more difficult intractable diarrhea when the patient has problem with defecation, liquid defecation, but doctor cannot establish its origin. Now to finish about diarrhea, I want to stop your attention on differentiation between small and large intestine diarrhea because if you was attentive, we said both pathology of small and large intestine may be manifested with liquid defecation diarrhea. If the diarrhea is caused due to pathology of small intestine, it appears rare 1 time per day, maximally 2 times per day, and feces is a lot amount because all hymus from small intestine evacuated independently. Large intestine diarrhea is characterized with often liquid defecation but with small portion because it is irritation of rectum and anus with liquid content. To differentiate small and large intestine diarrhea, we must ask the patient about time defecation, often of defecation, and amount of feces. Opposite problem, constipation. Feces becomes hard and difficulty evacuated. We differentiate two types of constipation, organic and functional. Organic constipation appears due to some anatomic defect and more grave if it appears due to mechanical obstruction. Usually, it is result growth of tumor, progressive growth of connective tissue, scar, or adhesion of large intestine as complication of some surgical treatment in the organs of small pelvis. Other mechanism formation organic constipation, there are any intestine abnormalities when the length of intestine enlarge and time of passage hymus along large intestine prolongate. You understand? If the time prolongate, all water maximally absorbed, feces becomes hard and difficulty evacuated. We are talking about megacolon, dolichosigmoid when the only sigmoid colon prolongate, megasigmoid when the sigmoid dilated and feces can be held into the sigmoid long time, and diverticulosis, local dilation of large intestine where may be kept sometimes feces. And we must remember about inflammation of large intestine, different types of colitis. If you attentive, you see all problem connected only with a large intestine. Constipation isn't characteristic for pathology of small intestine. You see patient with mega sigmoid. You see a sigmoid dilated and understand a difficulty feces go along this part of intestine. Functional constipation. Sometimes not needed specific treatment of intestine because it is caused by outside problem. And first of all, we must remember about our diet. Elementary constipation is characteristic for people which abuse hard food with cake, which diet is poor of fruits and vegetables. Functional constipation is characteristic for the senile patient when the flaccidity of the breath appears and lack of physical exercise. It may be a result or main symptoms of specific pathology. Irritative bowel syndrome is functional disorder of large intestine, which first of all characterized with disturbed defecation, one from which may be constipation. We must remember about secondary constipation, which appear due to primary pathology of other organs. And first of all, we must remember about thyroid gland. If you remember, thyrotoxicosis stimulate motor activity of intestine, hypofunction of thyroid gland, depress activity of gastrointestinal tract, and result patient predilected to constipation. Also, some poisoning with lead, morphine, as exogenous poisoning, and in neurogenic constipation, it's more often problem of the patient which treated in neurological department. First of all, maybe affection of central nervous system when the primary impulse is depressed in central nervous system. There are any pathology of the brain, growth of tumor, its inflammation, brain stroke, or it may be a refractory depression of the large intestine of the patient with other pathology, and first of all inflammation of gallbladder and prostate in the man tightly connected with activity of large intestine. No, why cholecystitis? Because bile is physiological stimulator of motor activity large intestine. In cholecystitis, properties of the bile change and as a result will be some problem with motor activity. Prostatitis, position of the prostate and rectum, refractory depression its activity. And last problem, which may be of the patient with pathology of intestine, which is hemorrhagic problem. When we are talking about intestinal hemorrhage, we must differentiate where is located source of bleeding, upper or lower part of intestine, because its manifestation will be different. If we are talking about upper part bleeding, it includes small intestine and large intestine before descending colon. Blood, which goes from this side of intestine, cannot be seen. We can see only its result destructive erythrocyte. We are talking about melena. If you was attentive, these signs of bleeding is characteristic for stomach and duodenal bleeding. Black color feces. Bleeding from lower part, which is lower part of descending colon, sigmoid and rectum, may be manifested with visible bleeding. Patient can see unaltered blood after defecation or on the surface of feces. And you understand which group of patients early can go to the doctor, but during inquiry, doctor must pay attention of the patient about on the all signs of intestinal bleeding, and if will be revealed some signs of possible bleeding, first of all we must exclude pathology which characterized with the destructive process, which is canceromatous process, which is specific affection of whole intestine, Crohn's disease, or only large intestine, not specific ulcerative colitis, which is growth of polyps as pre-canceromatous process. It may be specific infectious problem, dysentery, helminthic invasions, and we must remember about hemorrhoidal bleeding. Now I want separate all problem about which we said last lecture and today on two groups. Problem which are more characteristic for pathology small or large intestine, because on exam when you will answer on the questions active inquiry of the patient with intestine disease will obligatory ask you only for small or for large intestine problem. Small intestine problem manifested with pain which localizes near the umbilicus in center of the abdomen, accompanied with rumbling sound into the abdomen because we can hear active peristalsis of liquid hymus along small intestine. Patient can complain of diarrhea, we remember, rare and with large amount of feces, and hemorrhage, which manifested only with melena. Large intestine problem, characterized with pain, but it localizes lateral sides of abdomen and may be local, only right or left flank, accompanied with meteorism, flatulence of abdomen due to collection of gas into the large intestine, maybe both diarrhea or constipation, and bleeding manifested with two signs, melena or unaltered blood during defecation. In diagnosis, will obligatory send our patient on instrumental examination, and if we think about possible pathology of small intestine, we can use two methods. Enteroscopy, but it's not full result because with special balloon endoscopic diagnosis we can slightly a prolonged site of exam intestine because initial part of small intestine ileum can be raised due to action of balloon, but all small intestine to see during this method impossible, only if pathological process localizes in initial part of small intestine. More optimal capsule endoscopy. When the patient swallows small capsule, which during its going along intestine, copy its photo, made photo, which then may be seen on computer. Maybe two types of capsule endoscopy. When the patient swallow capsule, then find its and during defecation and bring the doctor, or maybe other method when capsule cannot become back because it's interconnected with portative computer and all information will be holding to the computer, capsule not needed. Large intestine, more easy exam, and first of all, if the pathological process localizes its lower part, first of all, patient complains of any discomfort during defecation or bloody defecation. We'll send him on rectal monoscopy, which is examination of lower part of large intestine, because rectoscope is metal tube with length of 40 centimeters. If the pathological process localizes upper, we'll send our patient on colonoscopy. Method resembles fibrogastrogenodenoscopy, but apparatus slightly longer and thick. If the patient badly prepared, sometimes we cannot examine initial part of large intestine, but now we have specific method of preparing of the patient for this examination, and all large intestine and sometimes last part of the small intestine may be examined in colonoscopy. Each is position of the patient in rectoramonoscopy or colonoscopy. Patient may be on site or may be placed on special chair. we can find source of bleeding, or we can find source of new growths. Upper slide is healthy intestine, which has pink mucus. X-ray examination, irrigoscopy. When the intestine will be filled with barium through the rectum with special enema, and depending on its filling, we can examine large intestine to reveal source of new growths. If you see on this graph, you see defect of filling large intestine, which is characteristic for tumor. Also, you see defect of filling, which is a result of new growths. Ultrasound examination not widely used for large intestine because it's very badly seen, and this manipulation not effective, sometimes for acute obstruction. CT scan more optimal when we'll find tumor, and mainly to examine surrounding organs because intestine better seen on endoscopic examination. Next question on which I want to stop, it is inspection of abdomen. I'll remember you that you will be attentive because it's questions which more difficulty answered on exam. Questions about inspection. When we are talking about inspection of abdomen, first of all, we'll pay attention on its shape, symmetry, when compared upper, lower, right and left side, body will be placed through the navel. We'll pay attention on the mobility of abdominal wall during breathing. It must be movable. And position of navel. There are obligatory positions on which you must answer on exam. If was revealed any specific pathological signs, some local affection of abdominal skins, visible peristalsis, protrusion due to growth of tumor or hernia, you will pay additional attention on these questions. When we are talking about shape, normally shape of our abdomen is oval or rounded depending on constitution. In pathology, abdomen may be enlarged. We are talking about protrude abdomen due to ascites, meteorism. And to differentiate ascites and meteorism, we'll put our patient on the back. Liquid moves abdomen to the side. We are talking about frog-like abdomen. Opposite problem, abdomen depressed, skyphoid-like abdomen, which is characteristic for patients with cachexia. And sometimes abdomen can be specifically enlarged and resembles apron. We are talking about loose hanging abdomen, which is characteristic for patients with obesity. Oval normal. In pathology, abdomen may be protrude, depressed, or specifically moves downward as apron. On this slide, you see skyphoid-like abdomen depressed to the spinal cord and resemble basin. And loose hanging apron type abdomen, each is insignificant. And on this slide, you see more significant problem, and you understand this patient obligatory must be operated because he cannot live normally. Symmetry. Normally, abdomen is symmetrical when we put line through the navel, vertical and horizontal. Both right, left, upper, lower part must be same. In pathology, asymmetry of abdomen may be result of enlarged abdominal organs, local protrusion of the abdomen. It may be result of hernia because weak abdominal muscles and protrusion in the organ through the wall under the skin and due to growth of tumor. I said you will obligatory pay attention on the mobility of abdominal wall during breathing, and normally abdomen movable. We are talking about active mobility, or we can say abdomen take part during breathing. In pathology, we not see movements of abdomen. Abdomen doesn't take part in breathing. Resembles desk, we are talking about like desk abdomen, which is a grave signs of acute surgical pathology, peritonitis, and this patient must be immediately examined in surgery department. You see patient with asymmetric abdomen, protrusion of the abdomen nearest umbilicus, which is umbilical hernia. And the navel position, normal navel depressed. In pathology, navel can protrude more often, which is characteristic for patients with ascites. Short time may be in pregnant woman or may be result of navel hernia. Skin of the abdomen may be characterized with local pigmentation or depigmentation. Hyperpigmentation of skin, especially over the epigastrium and right hypochondrium, may be of result of often using hot water bottle to relax specific pain, especially a patient with peptic ulcer, gastritis, or cholelithiasis. We can see different eruptions of the abdominal skin, especially patients with liver diseases due to skin itching. We can see some hemorrhagic spots, which may be result of systemic blood diseases, or sometimes it may be characteristic for the patient with progressive liver diseases, on which we'll stop next lecture. We can see different scar, which may be post-operative or may be specific scar, which appears without trauma but due to decreased elasticity of the skin and named as stria gravidarum, which are characteristic for patients with obesity, with some endocrine disorders, and for the woman after repeated pregnancy. Sometimes on the abdominal wall may be seen dilated veins. It may be a result of specific diseases of vessels, as you see on second slide, and on first slide vein has specific picture which resembles medusa head. And this symptom is called as caput medusa, which is characteristic of the patient with liver cirrhosis. You see patient with stria gravidarum. You see post-operative scar will obligatory show that it's located along linea alba. Each is right color, which indicates that each is fresh and may be result of surgical treatment of the stomach, duodenum, or gallbladder and liver. Sometimes may be seen visible peristalsis of the intestine. We see specific wave which go along the way of intestine. Physiologically, it may be a patient with asthenic constitution, but more often it is characteristic for patients with acute obstruction of abdomen when the peristalsis appears above obstruction. You see patient with umbilicus hernia due to enlarged abdomen because excited, and if you attentively see on this slide, you can see visible vein caput medulla because a patient with progressive alcoholic liver cirrhosis. You see hernia in the woman in which was repeated operation and due to weak muscles through the which easy protrude intestine under the skin, and you see specific stria gravidarum. Specific manipulation which helps reveal hernia of the linea alba. After inspection of abdomen, we allow the patient to raise the head, and due to tension of abdominal muscles, we can see as intestine moves through the rectus abdominal muscle because they separating, which is provoke fractures of hernia linea alba. You see local hypopigmentation, patient with pellagra, and also hernia with visible peristalsis of intestine because all intestine moves under the skin, and through the thin layer we can easily see its motility. Also local visible peristalsis, patient with acute obstruction of intestine. And last question on which I want talk today is topography of abdomen. Not difficult question, but you forgot how abdomen may be divided on some topographic areas. First of all, we'll put two horizontal lines through the rib arch and iliac bone. As a result, our abdomen will be divided on three parts: epigastrium, mesogastrium, and hypogastrium. Then we'll put two vertical lines along the external 8 of rectus muscles, and every preceded side divided on three sides. As a result, we have 9 topographic areas of abdomen. Epigastrium divided on area epigastrium propria and 2 hypochondria, right and left. Mesogastrium also divided on three parts: central umbilical and 2 lateral, right and left flank. And lower part also divided on three parts: central suprapubic, which not characteristic for pathology of digestive system, and 2 ilia-inguinal region, right and left ilia-inguinal region. Topography of abdomen helps clear pathology and find organs which may be affected, because if you compare our topography with anatomic position of inner organs, you can understand how can it help you in diagnosis process. Next question on which we'll stop today will be examination of the patient with gallbladder and pancreas diseases. I'll give you both organs today, same time, because they tightly connected with common duct through which bile and enzymes of pancreas enters into the duodenum. If you are talking about pathology of gallbladder, it localizes on the right lobe of the liver in right hypochondrium, and main its function is concentration and evacuation of bile. We can live without gallbladder, but in this case, bile immediately from the liver will enter into the duodenum due to low concentration, sometimes problem with evacuation, maybe some discomfort and dyspeptic disorders. Main pathology of gallbladder is its inflammation. We are talking about therapeutic pathology, chronic cholecystitis because acute purulent inflammation, which is surgery pathology. Patient with acute cholecystitis hospitalized in surgical department because sometimes needed cholecystectomy. Chronic cholecystitis corrected in therapeutic gastroenterological department. Cholelithiasis. Primary diagnosis in therapeutic department are then depending on order and dysfunction of gallbladder may be recommended for surgical correction. If you reveal cholelithiasis on stage which you see on this picture, on maybe only one prescription surgical treatment because this gallbladder off and cannot take part in digestive process. Functional disorders of gallbladder motor activity divided on two types. Hypomotor dysfunction, you understand, gallbladder contracted slowly and evacuation of blood delayed, or opposite hypermotor dysfunction when the contraction of gallbladder very fast, sometimes discomfortable for the patient, and sometimes bile cannot be completely concentrated. And dysfunction of sphincter Oddi, which control process evacuation of the bile into the duodenum, more often appears as complication post-cholecystectomy, and this problem is called as post-cholecystectomic syndrome. I said you about some problems of the patient when the gallbladder removed, and bile not concentrated enters in duodenum and regulated only with activity of sphincter Oddi. If you see on next slides, you can see compared to gallbladder, enlarged dilated gallbladder, which is characteristic for hypomotor dysfunction, and small gallbladder, which is typical for hypermotor dysfunction. And you see two patients with dysfunction of sphincter Oddi on upper slide. Contraction of sphincter Oddi prolonged, which restrict evacuation of bile. As a result, it is hold in bile duct, which dilated. A process of digestion disturbed. And opposite problem, when the sphincter Oddi not completely closed and bile all time enters into the duodenum, which irritate it and provoke duodenitis or peptic ulcer. Complaints of the patient with pathology of gallbladder may be divided on some syndromes. First of all, each is painful syndrome with specific characteristic of pain. Dyspeptic disorders because bile needed for normal digestion of the food into the duodenum. Like we said, if the organ take part in digestive process, we can say about dyspeptic disorders due to the functional restriction. Inflammatory syndrome, jaundice syndrome, and Phoenix syndrome. When we are talking about painful syndrome, I'll again remember you order of its characteristic. First of all, we'll clear location and irradiation. Then give characteristic of pain, which depends from structure of organs, and name provoke and some releasing factors if they are presented. Patient with pathology of gallbladder feels pain in the area of right hypochondrium. More clear, each is crossing of rectus muscles, right external edge with rib arch. You see as patient show on this picture. It's classical location of pain, but sometimes pain can spread in epigastrium region, and in this case, we must differentiate with pathology of stomach. Pain irradiates upward to the right, in right shoulder girdle, right scapula, right side of the spinal cord. Pain located in right hypochondrium and irradiates upward to the right. If we are talking about character of pain, it will be different depending on pathology. Gallbladder is hollow organs and as preceded pathology stomach and intestine, it also can give two types of pain, spastic or distensional. If our patient with cholecystitis or hypomotor dysfunction of gallbladder, pain will be distensional because affected wall of the gallbladder cannot adequately concentrate bile, its amount increases, gallbladder dilated, hypomotor dysfunction due to weak and slow contraction, also some bile delayed into the gallbladder. Patient complains of persistent, boring, dull pain. Sometimes instead of pain, he feels pressure, heaviness, or distension in the right hypochondrium. This problem intensified after taking fatty food or roasted or spicy food because this food needed more intensive activity of the bile process delay. Other character of pain. If our patient with cholelithasis or hypermotor dysfunction, patient feels spastic, sharp pain. Sometimes during attacks of cholelithasis, when the stone obstructs bile duct, pain has specific attacks order. We are talking about biliary colic or hepatic colic. This pain is provoked by jolting, running, jumping movements or taking fatty food because active contraction of gallbladder will be felt of the patient as spasm. Dyspeptic complaints. I said you, gallbladder is sac which concentrate bile which enters from the liver and then evacuate it after eating. Bile is needed to control pH of intestine where alkaline reaction, on contrary from acidic reaction of the stomach. Bile needed to activate activity of the pancreatic enzymes because primary they non-active and activated only into the duodenum, and bile needed for emulsification of fat before digestive process. You understand what problem may be of the patient if the bile not concentrated, not evacuated in time, delayed, or opposite very fast but with definite properties. First of all, will be problem with digestion of fat. As a result, patient feels specific bitter taste in mouth. Maybe lactation because any problem with digestive process accompanied with intensive formation of intermediate gap which push on the sphincter and it's easy come back through the mouth. Maybe nausea because absorption into the blood some intermediate toxic substances which is formed due to decreased activity of the bile and pancreatic enzymes as a result. You understand if patient feels discomfort after eating, his appetite decreases because we'll feel good appetite only if the taking food accompanied with some dishes. And as a result of abnormal digestive process, problem with defecation will be constipation or diarrhea, We remember bile is physiological stimulator or stimulator of motor activity large intestine. If the digestive process disordered due to formation of gas, due to problem with evacuation of hymen, patient can feel distension of abdomen or some rumbling sound because feel passage of hymen along small intestine. And I give next problem, vomiting, and you see I separate it from other problem because vomiting of the patient with gallbladder diseases hasn't dyspeptic origin. It's not appear due to disordered digestion. Vomiting as signs of dyspepsia may be characteristic only for stomach pathology. For other organs, it appears as a reflectory act, and in our case, vomiting appears as reflectory act on severe spasm of gallbladder, which spastic movements transmitted on upper part of digestive system, duodenum and stomach, and its contents will be removed. We are talking about vomiting. I want that you understand, because if the vomiting is result of dyspepsia, it may be corrected with correction of digestive process. But in our case, it's impossible. Nausea is dyspeptic complaint. Vomiting is reflectory act on severe spasm of gallbladder. Jaundice, yellowish color of skin, appear due to increased level of bilirubin in blood, which provoke of obstruction bile duct. When the bile cannot be adequately evacuated, it's delayed into the liver and absorbed into the blood. Patient complains of jaundice. You understand, it's more characteristic if the gallbladder will be filled with stone gradually. Because if a patient enters with biliary colic as manifestation of cholelithiasis, due to removing of pain and restored passage of bile, no time for formation of jaundice. Inflammatory syndrome is characteristic for cholecystitis, bacterial origin, and manifested with subfebrile fever. Because hectic or other types of fever indicates about acute purulent inflammation, and each patient, group of patients of surgery department. And at last, actinic syndrome. I separate it from all other problems because it's not specific. It may be in any diseases, and if you remember, I said you, activity actinic syndrome indicates about activity or gravity of pathological process. Then more severe pathology, then more weak patient, then more intensively it's fatigue, then more significantly disturb his vital activity, decreased work capacity, decreased interest to surround it, and all other problem with sleepiness, problem with vital activity. And if you finish your answer with actinic syndrome, it shows that you deeper understand problems of the patient, but only at the end, because it's not specific problem for gallbladder disease. Now, let's again come back to complaints of patients and separate them depending of problems. We said about four main problems, each is cholecystitis, cholelithiasis, and two motor dysfunction. Let's see how will be combined complaints of the patient depending of pathology. If our patient with chronic cholecystitis, inflammation of gallbladder, patient complains of pressing, dull pain, which obligatory accompanied with dyspeptic complaints, may be subfebrile fever, or if disease chronic, prolonged, repeated after some times, will be some discomfort in life activity. We can say about ischemic syndrome, not intensive. Cholelithiasis is characterized with sharp spastic pain, sometimes biliary colic, may accompany with dyspeptic complaints in case when the gallbladder will be filled with stone gradually. It's obligatory accompanied with jaundice. Attacks of biliary colic may manifested with fever because if the stone not smooth during passage along the biliary tract, may be some traumatization and secondary inflammation, cholangitis. Hypermotor dysfunction manifested with pressing pain which resembles cholecystitis, accompanied with dyspepsia because delayed evacuation of bile, disturbed digestive process, but no fever and no epidemic syndrome. Functional disorders cannot significantly disturb life activity, and patient long time cannot go to the doctor. Hypermotor dysfunction, depending on pain, resembles cholelithiasis, but it's not accompanied with jaundice, with fever, with biliary colic, only periodic spastic discomfortable pain, but obligatory with dyspeptic complaints because not regular evacuation of the bile. Inspection of the patient with gallbladder disease is not rich with visible signs. We can see only patient with cholelithiasis and only during attacks of hepatic or biliary colic when the stone obstructs bile duct. Patient feels severe spastic pain. He finds position which can release it, but it's impossible. Patient restless. We can see that it's ptosis in the pad. If the gallbladder filled with stone gradually, patient can enter in hospital with yellowish color of skin, jaundice. And we must remember that patient with hypertonic constitution, patient with predisposition to obesity, predilected to cholelithiasis because disordered fat metabolism provoke fractures, formation of cholesterol stone in gallbladder. Method examination of the patient. Physical examination. We'll use palpation of abdomen, but gallbladder, a specific soft organ, normally impalpable. In healthy people, it's impalpable. But to reveal pathology of gallbladder, we'll use specific symptoms, and on exam, we'll ask you about demonstration of painful points with percutaneous reflexes and specific pressing symptoms, Karam and Murphy, and Courvoisier symptoms, which is used for differential diagnosis between gallbladder and pancreatic jaundice. Methodic of these symptoms you can see on practical classes, but you must know on what problem you must pay attention when you will prepare for exam, because every question will be given on exam. Percussion of gallbladder, not used to determine size of the organ, it's impossible, but with percussion we'll check tapping symptoms, which also helps clear pathology of gallbladder. 3 tapping symptoms, Ortner, Lapine and Vasilenko will ask you on exam. Instrumental diagnosis, and first of all we'll give predilection to ultrasonography because it's more optimal, because no complication. Patient not needed special preparing except more better if he will be exam on empty stomach because during eating gallbladder contracted and sometimes difficulty reveal some pathology. Ultrasonography shows size of gallbladder, thickness of its wall to diagnosis inflammation, presence of stone, and helps control motor function. Next method, X-ray examination, rare used in our practice, but it's obligatory indicated when we establish cholelithiasis, because if the stone will be revealed both ultrasonography and X-ray examination, it showed its calcium origin, and this patient may be treated only with surgical method, cholecystectomy. But if the stone revealed only ultrasonography but unvisible on X-ray examination, it shows its cholesterol origin, and such group of patients may be corrected with therapeutic measures. I seen some students listen about ursodeoxycholic acid, which widely used for dilution of cholesterol stone. CT scan, usually rare case used for diagnosis of gallbladder only in case of new growth, which also rare located into the gallbladder. As for any organs, together with exam organs, we can see surrounding organs to check metastasis. You see ultrasonographic examination of gallbladder, and gallstone gives specific acoustic weight. On X-ray examination into the projection of gallbladder, you see groups of stone, which resembles the shape of gallbladder. It shows that whole gallbladder filled with stone. And last question on which we'll stop today, which is examination of the patient with pancreas diseases. Pancreas is organs which has two functions. Exogenous as digestive organ and endogenous as organ endocrine system, because products insulin. About endocrine function we will talk with you on other lecture. Today we'll stop on its exogenous function, and we examine pancreas as an organ of digestive system, gland of digestive system, because pancreas finish digestive process into the duodenum. It has specific anatomic position, upper part of abdomen from right to left hypochondrium. And if you see on this picture, you understand sometimes problem with pancreas might be differentiated from liver, stomach, transverse colon due to anatomic position. Enzymes of the pancreas enters into the duodenum through the common duct together with bile, and I said you both organs tightly connected, because if there's some problem into the common duct or increased pressure into the duodenum and some bile regurgitated into the pancreas, activation of its enzymes will be into the pancreas, and as a result, its self-digestive process, which manifested with acute pancreatitis, pancreonecrosis. But today we'll stop mainly on chronic pancreatitis, chronic inflammation of pancreas, which corrected in gastroenterological therapeutic department. Cancer process, primary diagnosis by therapeutic physician, are then treated in specific oncological department. Complaints of the patient with pancreas diseases. First of all, pain, then dyspepsia, because pancreas finish digestive process. Patient can complain of nausea and vomiting. Maybe jaundice, but if the process chronic, patient obligatory progressively loses weight. 2. Rapid cachexia in grave cases, usually in growth of tumor. Pain, depending on anatomic position of the pancreas, localizes in upper part of abdomen. It can start from any side of abdomen. If the pathological process localizes into the head, patient feels first of all problem in right hypochondrium. If into the body, in epigastrium region, if a pathological process involves tail of pancreas, patient feels pain in left hypochondrium. But I'll pay your attention. In any case, pancreatic pain has specific characteristics. It's obligatory spread along whole trunk. We are talking about specific Godlin character of the pain, which is characteristic only for pancreas and help differentiate it from the liver, gallbladder, stomach, intestine pathology. Pain in upper part of abdomen with obligatory Godlin character. Irradiation of the pain upward to the left shoulder girdle, left scapula, left side of the spinal cord. Pain has boring, dull character because pancreas is parenchymatous organs. It's prolonged, disturbed life of the patient. In chronic pancreatitis, it's more intensive, sometimes with vigor of onset. In acute pancreatitis, it may be result of biliary colic as complication, or if the patient abuse alcohol or any toxic alcoholic substances. And if the pain very severe, prolonged, difficulty released, we must think about possible new growth tumor. But in all cases, I'll again remember you, pain has specific Godlin character. And next slide, I think, helps you remember about this specific characteristic of pancreas. Patient complained and explained that pain constrict his trunk and divide it into parts. Nausea and vomiting. I'll pay your attention. Nausea may be a result of dyspepsia due to absorption of the incompletely digested toxic substances into the blood, as for any organs, for gallbladder, for intestine. But vomiting has other origin. It's not result of dyspepsia, because vomiting is removing of stomach content, where pancreas, where stomach. Vomiting had refractory character as result of severe pain, which is characteristic for patients with acute pancreatitis and cancer, or as a result of intoxication, again, which is characteristic for acute pancreatitis because pancreas necrosis or new growth. Vomiting isn't characteristic for the patient with latent chronic pancreatitis. Nausea, yes, as a result of dyspepsia. And if we are talking about dyspepsia, we remember problems which may be a result of incompletely or not finished process of digestion into the duodenum. As a result, discomfort and poor appetite, especially after taking fatty food, and sometimes patient feels aversion to fatty food. It's accompanied with nausea, meteorism, because lot of intermittent care, and as a result, diarrhea, because organism want to remove undigested hormone to prevent intoxication of the organism. Diarrhea has specific characteristics. Feces are lustral because they are rich with incompletely digested fat, and sometimes we can see white coating as not digested fat. It is dyspeptic problems of the patient with exogenous pancreatic insufficiency. We said that patients with prolonged chronic pancreatitis cannot be predilected to obesity. Usually, he progressively loses weight, and after pancreas necrosis or due to new growth, sometimes patients such significantly loses weight that we are talking about cachexia, because absent intestinal digestion, i.e. duodenum digested not complete, food cannot be absorbed in other side of small intestine. Jaundice appears due to outside obstruction of the common bile duct if the pathological process localizes into the head of pancreas. It may be pancreas sclerosis due to repeated exacerbation of chronic pancreatitis, or it may be growth of tumor. In this case, jaundice appears slowly, latently, and after a long time, patient can see or his family can pay attention that color of skin becomes not healthy because we see yellowish teeth. More often, such jaundice accompanied with skin itching. Why? Because due to disturbed evacuation of bile, its pressure into the liver increases, and together with bilirubin, cholesterol into the blood will be absorbed bile acid, which irritate specific skin nerve ending and clinically manifested with severe skin itching. Patient cannot sleep. As a result, he cannot adequately work and his life significantly disturbed. Jaundice accompanied with latent, slowly developed jaundice with skin itching, more characteristic for new growths, tumor of pancreas head. Inspection of the patient with pancreas diseases as for gallbladder. Not rich with pathological symptoms. No, we can see specific half-bent posture of the patient in case of severe pain. We can see that patient progressively loses weight. His skin becomes yellowish color. Sometimes skin scratches, result of skin itching. Maybe some hemorrhagic spots. All these symptoms more characteristic for the canceromatous process. Patient with usual development of chronic pancreatitis visually has long time, only slightly decreased weight. But patient with new growth, his condition progressively change and will loses this group of patients during 2-3 months from the beginning of disease. Palpation of pancreas used for diagnosis, but pancreas also as gallbladder has specific soft structure which resembles subcutaneous fat tissue. As a result, healthy pancreas impalpable. To reveal its problem, we'll again use specific symptoms, painful point and visceral cutaneous reflexes, about which we'll ask you on exam. We'll send our patient on additional examination and widely used laboratory method, biochemical examination of blood and urine to reveal level of amylase. Blood amylase increases of the patient with exacerbation chronic pancreatitis, patient with acute pancreatitis with new growth. The urine amylase used rare for diagnosis because this method is effective only when examined fresh warm urine. urine which was brought from the home cannot be examined because no adequate result. Patient must urinate nearest laboratory and immediately to bring urine for examination. And fecal elastase, which is gold standard for diagnosis of exogenous pancreatic insufficiency. This method helps clear activity of the pancreatic enzymes and correct treatment for compensation pancreatic insufficiency. From instrumental method, first of all, ultrasonography, because it helps assess structure, size, anatomic position of pancreas. We can reveal growth of tumor, we can reveal some formation of small stone, calcinate into the pancreas, which helps explain about progressive pancreatic insufficiency, cyst, because it's minus active tissue. We can use computer tomography, usually for diagnosis of canceromatous process, and X-ray examination, not specifically for pancreatic pathology. It may be as casual result because we'll send our patient on X-ray examination of stomach and duodenum because patient feels pain in right hypochondrium. Except duodenum, you see problem with pancreas if the pathological process localizes in head of pancreas. Patient feels discomfort right hypochondrium, but if you remember anatomy, duodenum covers the head of pancreas, and due to its enlargement, position of duodenum will be changed, which can be easily seen on X-ray due to visible barrier which introduced into the stomach and duodenum. Respiratory test, widely used, comfortable method without any complication, without contraindication. We'll use 2 triglyceride and starch test depending on specific breakfast, but in both cases it's marked with carbon, which may be exhaled of the patient after eating. You see ultrasonography, and in projection of the pancreas you see dark black spot, which is cyst of the pancreas body. On next slide you see a dark spot in the projection of tail, cyst of pancreatic tail. CT scan also reveals some dark spots in the projection of the head of pancreas, which is cyst. Respiratory test, I explained its technique when we said about diagnosis of Helicobacter pylorus, pathology of the stomach and duodenum, same order. Patient exhale air before breakfast and after breakfast, and then both suck will be examined in infrared spectrometer, and depending level of carbon dioxide we can assess functional activity of pancreas. In starch test, we'll give the patient breakfast, which includes 60 grams of cornflakes with small amount of skimmed milk. After which patient exhale air to control level of carbon dioxide because breakfast marked with carbon. And you see two red, upper red itches no, and lower yellowish indicates about decreased functional activity of pancreas. At the end of our lecture, I want to stop on characteristic some pathology of the gallbladder and pancreas. More often, we'll meet of the patient with chronic cholecystitis, inflammation of gallbladder. Such group of patients feels pressing pain in projection of gallbladder, right hypochondrium, which accompanied with bitter taste in the mouth and constipation as a result of dyspepsia, and subfebrile fever, which indicates about inflammatory process. During mechanism formation of cholecystitis, Provoke factors is preceded motor dysfunction of gallbladder because disturbed bile passage and bile evacuation will be changed its chemical properties and can be provoke factors some allergic components. And primary may be a bacterial inflammation of gallbladder and cholecystitis manifested without fever. But if this process prolonged due to abnormal activity of the bile, may be changed pH of intestine and as a result formation of intestinal dysbacteriosis, as a result pathological growth of pathological bacteria, and primary sterile bile becomes bacterial. I'll again come back that provoke factors of cholecystitis is primary motor dysfunction, hypomotor dysfunction, cholestasis, which complicated with decreased activity of the liver reticular endothelial cells, which main function is protective function. If protective function decreases, sterile bile becomes bacterial, and we can have chronic bacterial inflammation of gallbladder, which will be manifested with fever. On examination, we'll reveal positive pressing and tapping symptoms. You understand when we'll tap or press on inflamed gallbladder, which localizes superficially, patient will feel some discomfort. We'll send our patient on ultrasonography, and you see that its wall becomes more thick, more than 3 millimeters, which is objective signs of inflammation, cholecystitis. Cholelithiasis, metabolic disease, which characterized with formation of stone into the gallbladder. Long time, disease may be latent and doctor and patient are known about it. Manifestation accompanied with severe spastic pain, biliary colic, when the stone moves and closes gallbladder or bile duct. It's accompanied refractory vomiting, sometimes jaundice. Casually, during full examination of the patient, we can reveal positive tapping symptoms before clinical manifestation because we'll tap on gallbladder, moves stone, patient feels some discomfort. But if the patient enters with jaundice, I said you, will differentiate inside obstruction from gallbladder or outside from head of pancreas. In this case, we'll check Courvoisier symptoms, will simulate movement of gallbladder, and if gallbladder movable, we are talking about positive Courvoisier symptoms, which indicate about outside obstruction. If unmovable, negative Courvoisier symptoms because it's adhesion to the liver due to repeated inflammation, because cholelithiasis often combined with cholecystitis or hypomotor dysfunction of gallbladder. Obligatory ultrasound or and X-ray examination to reveal stone and clear its chemical origin to clear treatment. Gallbladder dysfunction on its clinical manifestation may resemble cholecystitis or cholelithiasis, but negative pressing and tapping symptoms because no inflammation, no stone, and only ultrasonography helps clear pathology. We'll examine gallbladder of the patient on empty stomach and then give some breakfast, after which gallbladder contracted, and depending volume on which gallbladder will contracted, we can differentiate hyper or hypomotor dysfunction. If the contraction less than 1/2 preceded volume, hypomotor. If more than 1/2, hypermotor dysfunction. Chronic pancreatitis, more often pathology of gastroenterological patient. Disease develops gradually. Patient enters in hospital with exacerbation 2-3 times per year, every year, no depend from his life activity, because provoked factors of exacerbation and formation of chronic pancreatitis is taking lot of medicine, because some patient treated without doctors long time because decide about his treatment independently. We must remember about alcohol. Acute pancreatitis, pancreanecrosis appears only after abuse of alcohol, especially in women after taking a small dosage of strong alcohol. We must remember about cholelithiasis, I said you, obstruction of bile duct, increased pressure, and provoke regurgitation of bile into the pancreas, which may be stimulated agent of its inflammation. Sometimes pancreatitis appears about heavy viral infections and COVID infection, also complicated with some pathology of digestive system, and as a result some problem in structural of pancreas and formation pancreatitis. Formation pancreatitis. This slight indicate as cholelithiasis can provoke pancreatitis. Clinical manifestation, patient complaints of boring pain. I'll again pay attention, obligatory with gargling character, accompanied with dyspepsia and decreased weight. In severe pain, we can see specific posture, maybe dry skin, decreased weight, especially if will be repeated diarrhea and vomiting due to hypohydration. Palpation of abdomen reveals painfulness in the painful points and positive viscerocutaneous reflexes. Will be increased blood and urine amylase, but fecal elastase decreased due to, because every inflammation finish with pancreas sclerosis, no active tissue, and specific changing of feces. Feces is rich with fat. We are talking about steatorrhea. Ultrasonography reveals increased size of pancreas, maybe only head, body, tail, or whole pancreas, and different structural changes such as cysts, as growth of connective tissue, pancreas sclerosis. Respiratory test, depending concentration of carbon dioxide, helps clear excretory function of pancreas, which will be progressively decreased, correlative with oftenly exacerbation of pancreatitis. That's all material about which I want to say you today. Thank you so much for your attention. We'll meet with you through the week.